So first and foremost, welcome to Nextech's MIPS Final Rule 2025 webinar. This is presented by myself, Heather Miller, and my colleagues, Christy Brantley and Megan Canterbury, are also on the line and will be available at the end for our MIPS Q&A. So let's start off. Hopefully that's not going to happen again. Just a quick disclaimer that the information provided in this webinar does not and is not intended to constitute legal or other advice. Instead, all of this information, content, and materials are available for general information purposes only. Information in this webinar may not constitute the most up-to-date legal, financial, or other information, and webinar attendees should contact their attorney, financial, tax, or other advisors to obtain advice with respect to any particular matter. If this webinar contains links to other third-party websites, any such links are provided only for the convenience, and Nextech does not recommend or endorse the contents of any third-party site. For our agenda today, we're going to first highlight the MIPS 2025 final changes. We will then jump into MVP reporting and what it will look like if you choose to report that in 2025. We're then going to get into some reporting tips, and at the end, we'll have a live Q&A with our MIPS expert team. So before we get started, I'm just going to launch a quick poll. In this poll, we want to know how confident are you in your current MIPS performance for 2024? Are you extra confident, mildly confident, or not confident at all? Just get a little bit understanding of who our audience is, and who I like seeing these confident, almost a 50-50 split between extra confident and mildly confident, which is a good feeling going into the last month of the year versus no confidence at all. Awesome. All right, so basically it's 44-56. So great audience here, feeling good about your MIPS. So let's talk about what are we going to see in next year for the 2025 reporting year. The 75 threshold did pass, so we will not see a change in the threshold to avoid the negative payment adjustment. It will maintain at 75. And it is projected and approved to maintain that through fiscal year 2027. So we've got a few more years where we will see a baseline threshold at 75 points to avoid those penalties. We still have the 4 options of reporting: traditional MIPS, the MIPS value pathways, which again pulled out in 23 as a voluntary option. It is not anything that's required, but it is an option. You still have your alternative payment models and the alternative performance pathway. So our 4 different ways that we can report our MIPS or quality payment to CMS each year. Our category weights: 2025 traditional MIPS and MVPs, 30% quality, 30% cost, 15% improvement activities, and 25% for promoting interoperability. Then you've got some APM entities that might have some different spreads because the cost category does get reweighted. And then the standard small practice now is the same as traditional MIPS. No changes there from previous year. And there it is in the traditional 30-30, 15-25 split. As far as payment adjustment goes, 9% is still that adjustment if 0 points are submitted. So if you are not going to participate, you could receive a 9% penalty. At 18.25 points, we will see then that adjustment begin to decrease up to that 75 point value, which would get you to 0%. So that would kind of adjust as a sliding fee scale till you hit neutral at 75. And then as we know, everything above 75 is a projection based off of the amount of penalties that have been collected. So that sliding scale could be anywhere from 2%, 3%. It all is going to matter on how much is actually collected on the negative side. Then those that are receiving higher points, we will see those positive adjustments spaced out from there. But every point does count. The higher you get to the 100, the higher the positive adjustment you would receive. Let's talk about quality and the final changes for 2025. We still have a 12-month reporting period. We still have 6 quality measures in which one must be high priority. We still also have a 75% data completeness. This does look to be in place through our calendar year 2028. So again, 75% of your eligible instances for each measure for the entire reporting year must be submitted to CMS. So this is critical to reporting because it allows you to achieve max points and get all of those points for that quality category. Now, one of the changes that did finalize in the quality category is the removal of the 7-point cap for specialty measures. So these would be determined annually. So every year, CMS is going to identify potential measures that have a 7-point cap to remove those to allow for that specialty to have enough measures to max points. We do know for 2025, measure 397, which is currently a 7-point cap measure, will be one of these that receives this new 10-point benchmark based off these performance rates. So every year, this has been approved that potentially a 7-point topped out measure could be given the new 10-point measure versus being topped out. So this is a final change and something that really is going to be helpful for our derm group, which was seeing a lot of capped measures and a really, difficult time getting enough measures to max points. As far as the final changes into the other quality measures, we did see the addition of 7 new measures, the final removal of 10 quality measures, and substantive changes to 66 of the existing MIPS quality measures. From the list of the possible new quality measures, 7 of the 10 were finalized. You can see that 3 of them that are crossed out were to be new measures that did not actually get confirmed. But the rest of these are going to be new measures, with the melanoma tracking and evaluation of reoccurrence as for our derm account, a measure that could be something to consider, especially when we look at those measures that were removed. This is where we had 11 potential measures to be removed. They only removed 10, and which one of them is that melanoma continuity of care recall system, which is really being replaced by the new measure, just a different way to collect the same information. One of the measures, the oncology, medical, and radiation plan of care for pain, was to be removed, and it did not get removed. So that one is still something that could be reported, but all of the other 10 measures have been finalized for removal. Some of the final changes regarding the quality measures, most of this is what was proposed, nothing really changed. For the A1C control measure, the test that determines that A1C does need to be part of that medical record. So we want to make sure that if you're doing this by patient report, it is not going to meet the updated quality requirements for this measure. For the diabetic retinopathy, this is actually being removed as a MIPS CQM collection type, meaning an electronic clinical quality measure, an ECQM, through your EMR will be the only collection type available for this measure. It also is changing the word. Instead of it being done within the exam, it can be completed soon after the dilated exam is performed. So if the letter or the communication happens after the visit, this will provide it some flexibility of when that is actually completed and sent to the primary care. For the diabetic eye exam, we've just got some removal of encounter requirements from those that are frail or have an advanced illness exclusions. And then in the closing the referral loop, this is a nice one for a lot of our clients that do report this, is now they are adding that one of the ways that you can close the loop is that this states that the patient did not attend the appointment. So I know in the past, a lot of people say, well, they never go, they didn't attend, and it never clearly stated in the rule that we could count that as closing the loop. So this is going to amend that, and now if you have some way of getting that communication back from that referred provider, whether it's a fax cover sheet that just has them check off that the patient did not actually create the appointment or attend the appointment, you could now close the loop according to the new specifications. For the functional status for hip, there's just some adjustment in the time frame. Some of our orthopedic groups might be looking at this. It's just a time frame change from November of the year prior to August of the year prior. And then in the psoriasis one, again, it's just doing that the follow-up visit must occur during the performance period. And then the big one here for probably everybody, if you're reporting the documentation of current medications, is that it is now must be completed on the day of the encounter, so instead of within the encounter, and the age criteria has been removed. So this is now on any patient, any age. We must be reviewing that current medication list and reconciling it with the patient. And then on the high-risk medications of the elderly, we did have some updates to the list of medications to align it with the 2023 AGS criteria. And that will look like this. So these are some of the medications that have been removed, others that have been added. And again, when we see that 2025 MIPS CQM specs come out, probably good to just review this with your doctors so that they truly know which medications are going to be considered a high-risk medication and count them into this measure. So that's the big changes in the quality category. Jumping over to the promoting interoperability, not a lot of change in 25. We're still seeing any consecutive 180 days. We still have the 4 reporting objectives as we have in the past. You still need to attest yes to the certified product. You also need to have the attestation review of ONC, and then you have your security risk analysis, and that you've completed the SAFER guides for your practice. All of this is going to be required in order for you to continue on with reporting the measures within the PI category. In the SAFER guidelines, it is a little confusing because there are multiple ones, but in the rule, high priority practices is the only one that is required for you to attest to. So if you want to complete the rest of them, that's great, but what you're attesting to is just completing the high priority practices of that foundational guide. Now, within the promoting interoperability, we still do have the automatic reweight for any small practice. It is still available, and that is anybody with 15 providers or less. Once you hit 16, that small practice would go away, and the PI category does become required. We also do have the minimum of 180 continuous days. There is one small change in the PDMP, which did become required to report last year. Last year, we had 3 different exclusions to choose from in reporting this if you are not doing PDMP. And they dropped the one about the burden of cost and replaced it, and now there are 2 PDMP. But the one, if you do not electronically prescribe any scheduled 2 to 4 drugs during the reporting period, this would be the exclusion you accept. The less than 100 exclusion has been removed. So there was confusion last year that it was less than 100 scheduled 2 to 4 drugs, but it was actually less than 100 permissible drugs. So that included all medications. So this year they have dropped those 2, kept the 1, and then this is the new one where if you do not electronically prescribe any of these drugs, this is the exclusion that you can apply and still be able to pass in the PI categories. Here are the point values. We still have 100 points, a couple bonus points if you do have connections with the public health, clinical data registries, or any syndromatic surveillance reporting. but we're looking for 100 points total to get those max points in this category. Also still seeing the options of health information through bidirectional exchange and then the exchange under TEFCA. I do believe over the next couple years, we're going to see some more changes in this category with the bidirectional and mainly with TEFCA exchange as that becomes more in the requirements for the vendors, as well as getting things a little bit more universal, which is really what TEFCA is going to do. Improvement activities, couple changes here. We're still on a 90-day reporting period. We still want this completed on 50% of the total providers from the practice. The big news is they did approve removal of 8 improvement activities, and highlighted in red are 3 ones that I know a lot of our clients use, particularly number 1, that 24/7 access to the MIPS eligible clinicians. So if that is a improvement activity being used by your practice, definitely want to jump in at the beginning of the year and evaluate the other improvement activities so that you've got something in place. Another popular one, the referral loop, is now also being removed, and same with the timely communication of test results. So 3 of those that I think a lot of people might have been using in the past are no longer going to be available moving forward. Now there are 2 new ones, one on lung cancer screening uptake and another on cardiovascular disease. Probably not going to impact our clients much, but bigger news is these 3 are going away. A lot of people ask why, and mainly because they're becoming obsolete. And mainly because everybody was doing them, they don't truly see them as a improvement activity if the bulk of everybody is completing those activities. So again, important for you to go look and see what's available and get something prepared for your reporting next year. Another change here was there was going to be modification to 2 current improvement activities. We did see the modification in the COVID-19 vaccine achievement for the practice staff, which would mean 60% of your practice were COVID-19 vaccinated, 80% influenza, and then 95% through hepatitis B. And then the other one was going to be on the engagement of the patient portal, and this one was not changed. So if you do have a portal that does allow for bidirectional exchange, then this is something that you could consider in the 25 reporting year, as it did not change to where it would have involved you implementing a new patient portal versus engagement of your current portal. So that is actually a measure that you could still consider, as the patient portals do allow for that type of bidirectional exchange with Nextech. Biggest change in the improvement activities is they eliminated the weighting of activities. So we no longer have to worry about it being a high weighted or a medium weighted and choosing those activities, because now all activities are created equal. A large practice will still have to pick 2, small practices will pick 1, and if you're going to choose to report MVP, same thing, there will be 1. All right, so the cost category. We do have a reporting period still of 12 months, and it's still doing claims-based submissions. We did get 6 new episode-based cost measures, none that truly will impact Nextech clients, as we're looking at chronic kidney, renal disease, prostate cancer, rheumatoid arthritis, and then respiratory infection and hospitalization. So each year we're going to see them adding these, so we'll see what happens next year, but for 25, these are the 6. One of the big changes is the scoring methodology update. This did get finalized. We are going to see this change, which is actually, I think, very exciting, because cost the last few years has been quite a sticker shock for a lot of practices. So in this new change, the median cost is actually going to set at 7.5. So for each of the measures, they're going to take the median of that particular measure, whatever that number ends up being, they're going to set it at that 7.5 mark, and then they're going to go a half a standard deviation down to set where you are in the different ranges. And in the couple examples that they showed in the rule, a practice last year that scored 2.9 in a measure, actually with this change would get a 6.9 in this measure with the same cost score. So with those benchmarks that are very tight, where we see a very small differential from the low end to the high end, we should see this being a fair, a more fair way for you to get scored and not have as much impact to your total score. So this is exciting news. We'll see how it pans out, but it did get approved. This was the old methodology where it was just by the percentile. They gave it the range. So this is giving it a little bit more of a true spread. And again, setting that median at 7.5 versus 5. Some of the other changes kind of specific to our clientele is modifications in the cataract, routine cataract removal. First and foremost, they changed the name. Previously, it was routine cataract removal. Now it's cataract removal with intraocular lens implementation. A couple things they did do is they reduced the exclusions. So as we know in the ruling, there were quite a lot of exclusions based off ocular conditions, and they have since changed that list. And those diagnoses such as glaucoma, macular degeneration are now going to be considered as part of the denominator. So in the past, they were excluded, and I'm going to show you here in a little bit what that looks like. But it is quite a few diagnoses that in the past didn't get included will be included. They also expanded services. So part of the, this 150-day review of the cost to Medicare does look at all of the services associated to that surgery. So now we're going to see telehealth services also included. Pre-op testing is going to be included. Emergency department visits for ocular complaints, as well as lenses and frames. So all of those V codes for lenses and frames are now going to be brought into the cost to Medicare along with these other expanded services. The last thing they're doing is they've included the cost for other medications. In the previous years, we were just seeing it for Omidria. Now we've got some with Dextenza and Iazo. So this is really going to set, to me, a new baseline of our cataract denominator base, which really could change the number of patients that qualify. And again, with just the expanded services alone, that annual or that episode average could really change. What I was able to do, and we do have a file of this, is you can pull the list of exclusions for diagnosis from the new 25 exclusion list and compare it to the 24 exclusion list. And it's going to clearly outline all of these new diagnoses that are going to be considered in that denominator. So I would definitely do that review, make sure you know which ones are going to now be part of the denominator, as well as the medications and, again, those services. So lots of change there, and we'll hope it pans out to the better. So now let's go into another poll, make sure everybody is awake and listening, and let's talk about which performance category do you perform best in? Quality, cost, improvement activities, or promoting interoperability? I was kind of wondering this. Nobody trusts cost, do they? Because we feel like we don't have a lot of control over it. But, a little bit came in there. But I think quality people are feeling confident in at 64%, 25% in improvement activities, 7% in PI, which I'm assuming a lot of people are taking small practice hardships, so might not be one that's at the top of your radar, and then cost down there at 4%. Awesome. All right, so let's talk a little bit about MDPs in 2025. This was one of the changes because CMS is committed to transformation of the current MIPS program through the MIPS value pathway, which is going to be a new participation framework. And the reason they did that, if we've all been told, is that we were reporting that the current MIPS program was too confusing. We believed we had too many choices when we were selecting measures that made it too hard. And then many of the measures are not relevant to the provider's specialty, particularly when we get to the end and we're being compared to our peers when in reality, we might be, reporting a total 6 total measures that are completely different than, our peer next door. So due to all of that, they basically came up with the MIPS value pathways, and they did have a pretty aggressive timeline to roll this out, but by 2026, we would see the end of traditional MIPS. That has been pushed out a little bit. I do believe COVID delayed some different types of the way the program was supposed to roll out. So we're probably not going to see the true retirement of MIPS until 2029, 2030. But in the meantime, it is voluntary there for you to report, and there is still 100% commitment to the sunsetting of traditional MIPS in the near future. Now, the good news is in 2025, we did get 6 new MVPs, 1 for ophthalmology care, 1 for dermatology care, 1 for gastro, another 1 for urologic conditions, pulmonology, and surgical care. And again, the whole idea of MIPS value pathway is to take these silos of the 4 different reporting categories, and merge them into where they become a fully implemented pathway. So let's talk about what that looks like. Now, if you go out to the QPP website and you go to Explore MIPS Value Pathways, you're going to find the finalized MVPs for 2025. When you click on this link, it's going to give you the full table of all of the different MVPs. And it's important when you're going to go report MVP that you really do look at the details of each of the categories to make sure you have the means to report the measures that are associated with it. So let's talk about ophthalmologic care. So if I was to go into this particular MVP, I'm required to select 4 quality measures in which 1 is a high priority or an outcome measure. So you'll notice from the list, we've got the measures, and out of them, I can choose those, the 4 that I feel are ones that the practice can score best in. Now, we do have some iris-only measures. We do have ECQM measures. We do have some Medicare Part B measures. But overall, this is the list, and every one of the MVPs is going to have its own specific list of what you can choose from. The second is going to be the improvement activity list. This also is going to be specific to each MVP. What do I have that I can report on here for that 90-day period for 50% of my providers? Nothing changes in the requirements. It's just the list is shorter, and you'd want to make sure something in here would be applicable for your practice, and if not, which one of these would you be able to begin using if you want to report as MVP in 25? Now, the cost measure is going to outline the cost measures that are applicable to the MVP. In the ophthalmologic care, it is just the routine cataract removal. Now, if you're a retina and right now you are not scored in cost because you are not performing cataract surgeries, this category would reweight in MVP the same way that it reweights in traditional MIPS. So we did confirm this with CMS to make sure that just because it's a required measure in MVP that you would get scored on this. If you do not have the cataract, the 10 needed, then you would not receive the score and it would reweight to the same percentages that we see now in traditional MIPS. So that is something we wanted to make sure everybody was aware of in the cost category within MVP. Now, outside of MVP, one of the big changes is the foundational layer, where there is one population health measure that technically would become your 5th quality measure. One of the way it makes it different is it is a administrative claim-based measure, meaning it's not something we track internally by a numerator-denominator report within our software or with a registry. Now, for derms or ophthalmologists or even anybody that's not doing hospital-based services, the 2 current population health measures that you would be selected on, both are on readmission rates and hospital admission rates and discharge rates. So basically, if you are not treating patients in the hospital, you wouldn't get one of these added to your score like other specialties that would. In the past, also, you're going to be asked when you nominate to report MVP to pick which one of these you want included. And they have changed this in 25, and now you will just get the one that you score the best in. So instead of having to elect it when you do your MVP enrollment, this will just get applied if, again, you're scored on it, and if you are, which one you scored the better in. So that's how that's going to pan out for the foundation layer. Other than that, everything else runs just the same, with the exception of 4 versus 6 quality measures. You still have the improvement activities, and actually the medium and high weighted is gone. It's just going to be 1 for small practice, 2 for large, and then the cost performance category will be based on the measure within the MVP. And this gives us a little bit more on that foundation layer, and then PI, no changes at all. Everything looks exactly the same point values, and the small practice hardship is still applicable, meaning you do not need to report PI if you're under 15 providers. All right, so let's jump into one more poll question, and let's talk about, do you know what is needed if you received an audit on your MIPS submission? All right, so we're going back a little bit more at 50-50 here. But nobody doesn't know what an audit is, so that is. And we thought we'd just give you guys a little bit of guidance in the tip section here. So when you're going and completing your upcoming 24 attestations, you've got some good tips on what you really need to be keeping on file in the case of one of those audits. So here are some tips for reporting an audit prep. Some of the reasons we always want people to stay in MIPS is, you know, we really don't, or anybody can't afford to lose more money. We earn 75 points to avoid that 9% penalty. And honestly, even if you aren't going to participate, you're just giving your money to the guy down the street. So really, I don't think anybody needs to just take those hits anymore, and give, again, your money to those that are not playing, because you're just handing it over to them. We'd love to see positive payment adjustments. So with money in your pocket, you do get some additional revenue that I think anybody would want. So setting that strategy and making sure you are monitoring your MIPS can result in true dollars back into your practice. And last but not least is we want to see great scores on our physician compare website. I think a lot of us forget that this is public information, and your MIPS scores do get translated into a 5-star score that is released on the Physician Compare website. And you would want yourself to be, you know, a 5-star, rock star status on that Physician Compare website. So when we're choosing the data that we present to CMS, remember that data does then reflect back on the Physician Compare website as a 5-star score. So just all good reasons to keep MIPS as being a priority in your practice and reap the benefits of what you can from the program. Just to kind of reiterate the 22 payment adjustment, 14% of those that participated received negative adjustments. And now in 22, we also still had the COVID EUC. So I do believe there's still a lot of impact to that EUC in these numbers. 7% received neutral and 79% received positive adjustments. So not so bad, but there still is definitely people out there that are not participating and receiving those negative adjustments. So how do I monitor my MIPS score and max out my points? And we probably say this over and over again in every single one of our webinars, but look at your reports monthly. Confirm what your MIPS score is. I know in our consulting groups, every month when we meet with them, our deliverable is a projected score sheet. If you ask them at any time, where are we with MIPS, they would pretty much be able to give you exactly what their score is and what we're working on to get them to increase that score should it need to be. We run PI reports monthly to target the best 180-day reporting period. So you're looking at that data and you're doing it consistently enough that you are confident in those scores. As soon as we see a gap, you need to address it. They grow quickly. So we want to make sure as soon as a score or we see a trend downward, we're quickly identifying what happened. Was it a new staff member? Whatever it is, get it fixed so we see those percentages maintaining and increasing. Look at and train your staff to follow up and ensure they're being consistent, because at the end of the day, if we become complacent, they stop doing the clicks. We all know it. It happens no matter what we think. So if we stay up on it, we keep them in the know, we let them know the why, and be a team effort, we can see some great things in our MIPS score. And then always check with your EHR vendor for updates on regulatory items. I know at Nextech, we try to do our best to keep you in the know when we're making those updates, when changes are coming. This is the whole point of this webinar series, is to make sure you know what's up and coming and get you ahead of the game. So are there any EUC hardships for 2024? Everybody always wants to know. I think we got a little complacent on them during COVID. But the circumstances would be that there was a reason you were unable to collect information necessary to submit for a MIPS performance category. We always like everybody to remember there needs to be a reason. Just because they offer an EUC, you should be able to substantiate that that reason caused you to have the inability to report your MIPS. And then if it impacted your normal practices, it affected your performance on cost measures, then you could potentially apply and support it. So for the 24, there is an EUC. The deadline to submit these is December 31st of 2024. And there was the Change Healthcare cyber attack that was in February of 2024, lasted a few months, but I know many practices felt impact for a much longer time. So if this is something that did impact your practice, there is an EUC application that you can get to the QBB website, log in. You need to make sure within that description you are including the words Change Healthcare cyber attack so that they know that that's the exact one. But the selection, I think, says malware, malware security attack, something like that. But in that descriptor, you need to make sure you're identifying that it was the Change Healthcare. And then what did it technically impact in your practice? Was it an all hands on because you weren't getting paid, because you weren't getting claim forms sent out, or you weren't getting whatever those instances were? Just put the details in there and see if you can get that approval. Some of the other ways that an EUC might happen is through natural disasters. We did have quite a few hurricanes that came back to back, particularly Hurricane Helene, where they actually designated 5 different states through FEMA, and if that is a designated FEMA state, an automatic EUC is applied in those zip codes. So if you are in a zip code, you can go and look at the actual FEMA designation. You will see maps that look just like this. And if you're in a designated disaster declaration area, then you will get an automatic EUC. It is not something like for the cyber attack you need to actually apply for. These will be automatically applied due to the zip code and the disasters that occurred within them. If you are in these and you get applied the EUC, if you submit data, it will trump the EUC. So if you want to accept it, you accept it. Don't need to do anything, but if data is received, you do want to make sure you submit all 4 categories so that you're not just getting data in one category, because that will trump the full EUC even if just one category is submitted. All right, so let's talk about audit requirements. So ensure compliance with MIPS by understanding performance categories. The biggest thing to know is, what are we giving CMS for the quality? What are we submitting for cost, for PI and improvement activities? And then know the documentation that needs to be kept. So we want to make sure you have accurate and complete records from your patient charts, your claims data, your performance data, and they match. And you're going to have to retain that documentation for the required audit period, which is 6 years. We do have a couple practices that were recently audited from the 22 submissions. And it is very important on that quality patient list that you submit to them, that numerator denominator list, that you're maintaining those and you're auditing those for accuracies. They will send a list you will have to go pull from your charts confirmation that the patient did get into the numerator correctly, that they got into the denominator correctly, that they got into the exclusions correctly. So we also need to make sure that you've got that data and you're confident that if you did get that list of patients, you could give them those details. We want you to be able to submit timely, accurate data with correct codes and modifiers, and that you're regularly reviewing data discrepancies before submission. So again, auditing that stuff before it ever gets to CMS will help you in battling it out if you find it during an audit, right? Some of the other triggers: discrepancy in data, outlier claims, unusual billing patterns, mismatched data across MIPS categories. So they're definitely looking for things that would trigger for your particular practice to get an audit. If you did get an audit request, do reply promptly and submit the requested documentation accurately. They will send a pretty detailed explanation of what they want, how they want it, follow it to a T. Can't hurt in any way to give them more than what they need. If you have questions, they are very communicative. You can communicate back and forth with them as you gather the information that they're needing. Address findings with an action plan to consider dispute processes if needed. So if you do find something that is in it, you provide them, hey, we came across this, here's our action plan, and make sure that you give them all of the details. And, you know, the impact of an audit, it can affect your payment adjustments. So if you were getting payment adjustments for the positive, but yet your data wasn't correct, maybe they take them aback. Penalties for noncompliance, and again, overall reputation risk. I would definitely consider those mock audits and train your staff for readiness. All right, so last question before we jump into any more questions, or last poll question is, does your practice have an internal MIPS expert or team that manages your MIPS? And we'll have yes, no, or at the end of the day, do you need Nextech? Love seeing that you guys have a sign. So about 75% of the group has a MIPS internal team or expert that manages. About 25% no, and a little 5% out there needing some Nextech. We'll make sure we reach out to you, or make sure you reach out to your ISM, and we can get you information on our consulting services that we provide if you do not want to keep it in-house. So I will jump over to our questions. I know the crew has been out there hopefully answering away. I haven't been paying attention to that as I was just making sure I stayed on topic. Megan, you want to chime in? Christy?
Yeah, we have, Heather. We've gotten some really great ones so far. I think there's a couple that would be great to address to the group. We got this really interesting one on some improvement activities that I think would be great to clarify. So just as a reminder to everyone out there, the improvement activity that is basically just kind of the implementation of closing the referral loop, that one does stand to remain until 2026. But unfortunately, you know, that provide 24/7 access to a MIPS eligible clinician or group is slated to be retired here in 2025. And we do know how popular that improvement activity is, and how important it is to everybody. So we feel that frustration of it getting removed also. But just wanted to go ahead and make that a point of clarification.
Yeah, and Christy here. So another good one was, what was the SAFER guide? I think that was a great question just to go over just what is SAFER guide. So SAFER guides are the new thing. I think this is second year. This will be the second year for required. But the third year, the first year was either a yes or no was accepted. But if you're testing for PI, this would be the second year that it's required. It is that high priority. If you go out, what I typically do is just go to Google and type in SAFER guides, and it pops up. So, so if you want to go check that out, you can, and you'll see the 9. It's 9, right? Megan, Heather, it's 9 guides, right?
Yes.
But the high
Yeah.
priority
Yes.
is the only thing that is required at this time if you're attesting for the PI category.
Correct.
And then I also loved the extra that I had, we received in the chat on kind of some additional webinars that we could do that would be helpful for clients. I did like that. So if we will put those down, I know some people had asked if we could do a webinar on audit preparation. So any, suggestions like that really comes in handy, so we could see kind of what would be helpful for you. That would be great. And then also the other is just remember, you will get a copy of the webinar in a couple of days on demand. So that was one question that was in the chat here of if you would get a copy of the webinar. So you will get a copy of that.
Correct.
And then
And it
I'll
looks
take
like
the
everybody.
one. Go
Yep,
ahead.
go ahead. No, I was just going to chime in on the ideas that everybody really is liking a more detailed one on audit prep. So I know with attestation season next quarter, maybe we could throw a webinar in. We do have our user conference, Edge, in March, which I do think some of our presentations hit on audit for those that would be attending Edge, but maybe we could squeeze one in and give it a little bit more content. I would think we could probably do something like that.
Yeah, and we did have an attendee state that they are learning so many new things today, so we really enjoy that feedback also. And Tefka, if possibly we could on another webinar go into that a little bit in more detail. But we do like the feedback that you are learning things. That is our whole purpose of doing these webinars. So thank you for letting us know that you have learned many new things today.
Well, and I'll take the one about, if Nextech has any suggested improvement activities, as with since they are going to remove some of our favorites here in 2024. And I think, we can all kind of brainstorm about this one. I know there's a financial navigation program. There's the one if you do a patient experience survey. There's one just if you're even integrated with a registry, the QCDR. Ladies, what other ones do you have just off the cusp? See.
You caught me.
Oh, darn. Well, Anna came out the good ones.
Most of my ones that are being used at this time are going to be gone, so I'm going to start doing some research on that real soon. But I do try to look at those improvement activities with the offices, because a lot of times practices are actually already doing an activity, and I'm not aware of that. So I do look at the list and just kind of go through. But I will be going through that list and kind of replacing some that are going away.
Yeah, and Vivian, you are right. Reporting an MVP is an improvement activity.
I was going to look into the details for that. I know that there is an MVP. I was curious what the data validation would be. Is it just that you're choosing to report it, or do you need to do some additional things?
I'm sure there is some caveats.
Yeah. I definitely think data validation file is the best way on some of these where we think we interpret it one way, but then they want specific things in place, and there might be some little nuances on that one. I know that I have a group that there's a training that is required for providers to do like every 4 years. One of them's on like opioids and narcotics, and then there's another one, and she flip-flops that one and uses it quite because they have to do it anyways. So I know that there is a training one there. And then there's always patient surveys. I know a lot of people don't like to always implement them, but that patient survey is still available, and it doesn't have to be like all annual year survey. You can do it twice a year, once a quarter, whatever it is, for a certain amount of time, collect the data, analyze the data, and implement change if needed. So it doesn't have to be like a robust survey through a company. It can truly just be a 5-question piece of paper that you have at checkout that you collect this many times a year, and you basically bring it to a team, analyze it, and if it's too cold in your lobby, you make adjustments, right? So whatever it is, it's just off patient experience while in your at your office. I don't know if any of you guys want to add to that, but it doesn't have to be as formal as I think some people think it needs to be.
Absolutely. That is a measure that is used, an improvement activity that's used quite often on my side with MIPS clients. So yes, we just need something as an improvement plan of what you did. And again, I go back to that, it being cold in the rooms. Maybe you put a heater in there or something like that to improve that for your patients. So there's multiple things that you could do with that.
Right.
And then one of the other questions is, will Nextech add to KB for closing the loop, patient did not attend appointment?
I do believe that right now the ECQMs haven't been updated for the new, and as soon as they are, they'll put that new drop in the drop set. Did that make sense?
Right.
Did you hear me?
Yes, absolutely. That was exactly what I was going to say, Heather. So I'm glad you took that. I'm just looking. Can we add that now? Not for 2024 reporting year, because it's not actually part of the measure for 2024, but it will be added in 2025.
Correct.
A lot of suggestions on that webinar for audit prep. And then I don't see anything else in the questions box. We just have literally a few more minutes. So if you have anything that you want to put in there, we still have quite a few attendees on, which is great. So if there's anything, any last question that anyone has, go ahead and put it out there.
Any questions on that cataract cost measure? I know there was a lot of details there. Just making sure.
I don't see anything else coming in at this very moment, Heather.
Will we receive printouts at Edge? Oh, love you too, Melissa. Crazy MIPS ladies, we are crazy, aren't we? For PI, if doctor has less than 100 referrals, he is an exception. Correct. So that would be for the receive and incorporate, and then the sending. But yes, if you have a less than 100 referral in the 180 days, you can still apply that exception. It is still there.
I do see this one question is just cataract measure coding ? But I'm not so sure I know what that means.
So I'm wondering if it is about the diagnosis codes and being able to know which ones are now going to be included in the denominator, the numerator that they are adding back into the measure. Is that what you're asking?
Yes.
Okay. So basically, let me pull up the file that I created. I'll share it with you guys. I did like a review of the ones from last year to this year. And I will show you. And actually, the other one, Vivian, Dextenza is not an exception. It will be included towards the cost.
Is that in
So
2024, Heather, or in 2025? I think it's 2024, right?
my impression everything was going to be retro to 24.
Okay, that's what I thought too.
I believe the cost changes are being, we could probably confirm that. I definitely know that is the case for the scoring methodology. I don't know if it's the case for these exclusions. We probably could confirm that. So this is the new list of diagnosis codes that are excluded, meaning they will not be, if the patient has any of these, they will not be included in the cataract. So when we look at that in comparison to the 2024 exclusion list over here, all of these in white are now diagnoses that if the patient has it, they will still be counted in the cataract cost measure. And a lot of it's going to be these open angle glaucoma patients, low tension glaucoma, there's your chronic angle. So you can see quite a few diagnoses related to glaucoma.
Heather, are you sharing your screen?
Oh, I thought I was.
I just see the poll question still.
Hold on, I think that, yep, hold on, I got to do this. My bad. I'm just talking away to myself over here. That's how it goes. So back to what I was explaining. Here are the exclusions for 25. These were the exclusions for 24. So when I run a comparable, anything in white is now going to be a diagnosis that would count in the denominator, where last year they were excluded. So all of these are the same. There's some in white, H21s. And then here's all those glaucomas. And the code files are out there. You can easily take these code files and then just do the comparable of the two. And as we get down to the end, you'll see some of the diabetics. There's all your type 1s, type 2s, other specified. So it's not just one or two, it's quite a few new diagnoses that we've seen excluded will now be counted in our denominator list. There's retinopathy. And then also I did a comparison of the service codes. So the same thing here, mainly lenses, all these V codes for lenses are going to now be included in the cost, service cost model. Some telehealth visits, and then, but mainly it's going to be those lenses and optical costs.
Thank you everyone for joining. I hope you all have a great evening.
Have a great afternoon. Take care.
Bye.